cases.
Right. So like how I told, today we are going to discuss the cases. The methodology which we are going to follow is first we'll be going through the main topic, the main lectures, and followed by the cases. Here in cases, what we are going to discuss is how exactly the model questions will be, what type of questions that are expected in the exam related to that particular topic. And during the discussion of these particular model questions, we are not only looking at the questions or the type of it, but also discuss briefly regarding the topic which it has touched upon. And also sometimes what happens is there will be new concepts to learn which were not discussed earlier in the main lecture. So this is how uh, the primary methodology is. And from the next session onwards, what we'll try to do is we'll also have the quiz format in a way like as of today, I'm going to discuss the MCQs, how to approach that particular question, how to evaluate, how to identify the right answer, and discuss what exactly that question is touching upon. And in the quiz, I'll give the chance to all the participants to answer that particular MCQ so that you're applying what you have learned. Before the next main lecture, we'll have a quiz. So today, basically, we are going to discuss the primary cases regarding quality basics. And most in today's session, it's me who is going to discuss. And in the next session, before the main lecture, when we have the quiz, I'll give you the opportunity to answer the questions and then discuss what the possible answers are. So this is the main difference between the cases and the quiz. I hope everyone understood. Right, we'll start with the first case. Right. Here, coming to the first question, it asks, the appropriateness of care is, right? So here the options are A, primarily a focus of utilization management, B, a key dimension of quality care, C, equivalent to case management, and D, the degree to which healthcare services are coherent and unbroken. So here the question is appropriateness of care is basically asking what appropriateness really means in quality terms. In a way, like what does it mean when we say the care is appropriate? So it's a straightforward definition question. So once we know what appropriateness is, then we can answer this particular question. But here, when we look at the options, in a way like primary focus of utilization management, this sounds like utilization review stuff where they control the costs or resources. It is related to appropriateness, but it's not the definition or the one which we might be looking at. Okay. And now coming to option B, yes, it's one of the classic quality dimensions like which we have seen in the last main lecture session. Option C, equivalent to case management. Yes, case management coordinates care, but it's not the same as appropriateness. And here D, the degree to which healthcare services are coherent and unbroken. This is a definition of continuity, smooth, unbroken care over the time. So we'll be eliminating D and C, but there's a close call between option A and B. But option A is a little narrow, and option B, a key dimension of quality, fits the question. Okay, this is one of the core dimensions of quality. So remember, appropriateness is a fundamental dimension of healthcare quality, right? It is defined as providing the right services that match evidence-based needs for that specific patient. There should not be any overuse or underuse, whether that's appropriate for that patient or not. Like in the last session, we have discussed the example of antibiotics. Okay, appropriateness I mean, like it is inappropriate to prescribe antibiotics for a viral, simple, common cold, right? So appropriateness is guidelines driven and it is patient specific care. So this is one of the simplest of the questions that we have come across. And regarding this utilization management concept, for those who are joining fresh, this we are going to discuss it in detail in coming sessions. But for you, in brief, utilization management reviews appropriateness to avoid any unnecessary test or treatment. Okay, so just remember that. And as far as the case management is concerned, it's a coordination of the complex care, which focuses on continuity and efficiency. Okay, so these two concepts which we are going to learn in the future sessions. Now, coming to our second question. Here, a medication is ordered for a diabetic patient. Its capacity to improve health status as a dimension of quality or performance is its what? Okay, so here the question is asking which quality dimension describes a medication's capacity to improve health status. Okay, for a diabetic patient, in plain terms, like in a way, like what do we call it when a drug has the ability to get to help the patient get better? Here the key is capacity. Capacity is the keyword in this particular question. Okay, so coming to the options, option A, effectiveness. In a way, like effectiveness is the real world performance of the drug as to how well it works in the real time patients who have problems with adherence, etc. So it's not just capacity. So effectiveness is not considered. Potential, yes, it's kind of vague. It's not a standard quality term and it's a distractor. Okay, for this question, potential is a distractor. Coming to appropriateness, appropriateness is the right drug. I mean, like, is it the right drug for the patient? This is about fit and not the drug's capacity or ability or power to work. Okay. And as we have discussed in the previous question. Now, coming to the last option, efficacy. Yes. Efficacy here, this is the drug's built-in ability to produce results under ideal conditions. This matches efficiency, the capacity matches the efficiency. So for us, option D is the right answer. Okay. Remember, even in the last session, we have discussed the key terms, what efficacy is, what effectiveness is, and what efficiency is. I'll just, I mean, like, just try to revise. Wherever you find the word capacity or ability, think of efficacy. And also, efficacy is mostly talked about in the controlled conditions, in the lab settings, in an ideal setting. Okay. Whereas effectiveness is related to the keyword of outcome. Effectiveness is outcome. And most of the times, this is related to the real world sort of settings. And it's not just the capacity, because you see, a drug might have a certain capacity to improve health. Capacity, its potential, let's say it's 90% in improving the health of a patient. But in real time, the effectiveness of that particular drug may be 60% only, because there are different types of patients who may adhere to the regimen, or who may, in a way, like, what do you say, have problem with taking the tablets on time, and there are various factors, comorbidities of the patients, etc. So effectiveness may be reduced in real world settings. And then coming to efficiency, optimum utilization of resources. This is what 3 E's. The confusion should not be there. You should be in a way, like, be able to come to the conclusion immediately. Capacity is efficacy, outcome is effectiveness, proper utilization of resources is efficiency. in this particular session of today, we are going to have many questions related to that. So you will have a easy understanding of the concept. Okay. Now, coming to the third question. What's the dimension of quality or performance that is dependent upon evaluation by the recipient and or observers of care? Okay, so try to understand the question. Here it's asking which dimension of quality mostly depends on how patients or family or people watching the care feel about it or judge it. Okay, so it's about perception based quality and not something we can count easily. It's not objective. It's not about a rate or wait times. It's about the perception, right? We have already discussed this particular thing in our earlier session. So here, coming to the first option, it's talking about respect and caring. Yes, in a way like this sounds very perception based. So here, the patient or the patient's family are having a perception. They're thinking, did the staff treat me kindly with dignity or compassion? Okay. So who is going to rate this particular thing of respect, caring? It's a patient or its family or the attendants, right? And now coming to the next option, that is safety. Here, safety is partly in a way like partly perceived. It's not 100% perceived. I mean, like most of the time, safety in quality is objective and is usually defined by those objective outcomes like any drug errors or falls or adverse events. And it's not just about safety. Okay, it's not just about feelings. Sorry. Coming to option 3, continuity. We have seen continuity is about ongoing coordinated care over the time. Okay, so it's measured from the system side and not the perception. And then coming to availability. Availability is what? It's about whether services and resources are present or can be accessed. And it's mostly a structural system measure. Okay, this is not any feeling. Availability is not a feeling. So out of all these options, what we get to know is here this particular option A of respect and caring is subjective and this is perception based. So here this is the right answer. Remember, respect or caring is the dimension that is almost entirely judged by the people receiving or observing the care, right? In a way like they will decide whether they were felt whether they felt listened to or were they treated with dignity, were shown empathy and cared for. Okay, so this is one thing which you should remember. And whenever the terms like respect, empathy, caring do come up, think about patient perceived dimensions. Okay, and also all these things will lead to patient satisfaction. And how do you calculate or how do you measure the patient satisfaction? It's through surveys, it's through feedbacks, and unless we are ask the patients or observers, we are not going to know how exactly they felt, right? I hope you understood this particular concept. Now, coming to the next question. So here, if in continuous quality improvement process, we increase our emphasis on customer satisfaction and outcomes of care, which two dimensions of quality or performance must be incorporated into all quality management activities? So in a way like this is asking like in CQI process to increase emphasis on customer satisfaction and outcomes of care, which two dimensions of quality must be incorporated in QMS? Like what is asking? It's asking like for better patient happiness and health results, which pair of quality dimensions do we add to our quality work? It's as simple as that. Okay. We all know CQI means PDCA cycle and adding patient focus means dimensions for how patients feel. That is satisfaction. And it's also talking about the outcomes of care, satisfaction and results. That is outcome. Okay. So here, once we see one is talking about the customer satisfaction, which is perceptive. One is talking about objective outcomes. Now, these two are the keywords of this particular question. Option A, availability and respect or caring. Here, see, availability means access to the resources. Here, it doesn't directly have any sort of impact on satisfaction or outcomes. Though respect and caring do link to customer satisfaction, the availability doesn't talk about outcomes, right? So, option A is not valid. Now, coming to option B, respect or caring and competency. Yes, respect and caring does fit in, but competency is not among the quality dimensions. Option C, effectiveness and respect and caring. Yes, this is because customer satisfaction is respect or caring, and then outcome is from effectiveness. Okay, so effectiveness and respect and caring is the answer. The other option is continuity and competency. Continuity and competency are helpful, but not primarily for satisfaction or outcome. So in a way like this is also eliminated. Okay. Now remember these two keywords, customer satisfaction or outcomes. Outcomes is for effectiveness, like how we have discussed earlier, and so as customer satisfaction towards respect and caring. In case if you have any sort of doubts or if you want to really discuss, you can kindly unmute your mics and ask me the question directly, and we'll be spending more time on discussing certain topics. No need to worry about that particular thing. Okay. I hope everyone understands this. Now, okay, the keyword outcome is for effectiveness, and we have already discussed this. Now, coming to the fifth question. Let me also know if at all I'm going fast or slow, because I just want to curate according to your understanding and everything. I just don't want to rush without making you understand what exactly that question or the topic is discussing about. Okay. Now, coming to fifth question, which of the following key healthcare issues is more problematic for ambulatory care than for inpatient care? So here it's asking about which key healthcare issue is more problematic in outpatient or ambulatory care setting when compared to hospitals or inpatient care. In a way like think about outpatient care or ambulatory care. Outpatient care struggles more with which issue compared to hospital stays. That's as simple as that. Okay. Now, in a way like remember this. Ambulatory care or clinics are less controlled. You all know that. And inpatient care means hospitals do have intense oversight, good teams, nice protocols, whereas ambulatory care does have fragmented and solo providers. Okay, so once you understand that, once you remember those particular things, it will be easier for you to crack this question. So coming to the options, is it reimbursement for care? So reimbursement means both OP and IP, hospital and the ambulatory settings, both will fight the payers. Both hospitals have billing departments and both will have similar issues, right? And now coming to access to specialty care, yes, outpatients here struggle a bit. Outpatients wait for some weeks or for months in some countries, in some hospitals, to get their referrals. But whereas hospitals will have the specialist consultations on the same day. This is one varying factor, right? And then coming to option C, appropriateness of training treatment settings. Here, this could be, but inpatient control settings are tighter and appropriateness for the treatment settings may not be the case. And then coming to option D, quality of care provided. I mean, quality is measured. Quality is like there is no more or no less when OP is compared to IP. So, out of all these options, option B, access to specialty care, stands out, right? So, the correct answer is option B, access to specialty care. So, remember, ambulatory care or OP generally faces bigger barriers to specialists because of referral delays, or there may be insurance hurdles. And also, there is a fragmented primary specialty coordination because they are two different entities completely. A patient may wait for weeks to months just to get the appointment of a specialist, right? So this does happen. And the other ambulatory challenges also include, like, there is a poor care transition and there is a specialist access gap. These are all the challenges that they do have. Whereas in IP settings, what happens is, in case if a diabetic patient, let's say, let's take for example, there's a there's a case of there's a diabetic case who definitely needs an endocrinologist appointment. As far as ambulatory care or outpatient care is concerned, that particular patient has to wait for about 2 to 4 weeks in order to get the appointment of an endocrinologist. So here, the access to specialty care is a challenge. But whereas if the same patient gets admitted to a hospital, then there is an instant, like instant consultation of that particular endocrinologist in the IP setting. So this is what the question was asking regarding. Okay. So here the challenge is access to specialty care. Now, coming to question 6, incorporating TQM key concepts, compartmentalization of quality management or quality improvement activities by organizational structure, that is by department or discipline, is what? Okay, so basically the question is asking, like, using TQM concepts, splitting the quality management or quality improvement activities by departments or by disciplines, in a way, like it's a siloing of the department wise. Okay, then what exactly it is, right? I mean, like, it's asking in as simple as, in TQM, what if we separate the quality efforts department wise, or if we separate everything, is it good or bad? That's the simple question. Now, coming to the TQM, we all know, what does TQM do? TQM means it's organization wide. It's cross functional, and it's against the silos. There should be no silos because everyone owns quality, right? Silos kill the TQM concept. So once you remember those things regarding TQM, it's easy for you to understand, go through the options. Option A weakness in implementing quality improvement. Yes, because we all know silos weaken QI by blocking cross departmental collaboration. So this is a likely answer. Okay. Now, option B, it is the most efficient structure. I mean, like, compartmentalizing leads to most efficient structure. No, because we all know silos cause duplication and blame culture, right? So this is not the right answer. Now, compartmentalization is consistent with TQM philosophy. No, it is quite opposite to it. TQM actually is against compartmentalization, right? And then compartmentalization is important for preservation of medical staff autonomy. In a way, like, yes, medical staff might like it, but it is not TQM aligned. We all know doctors, physicians, they value independence, but TQM requires shared accountability. Everyone is responsible. Autonomy is preserved via participation, but not through isolation. So this is also not a TQM concept. And it's a weakness in TQM implementation rather. Okay. So looking at it, the correct answer is option A. The compartmentalization of QA activities department wise is a weakness in implementing quality improvement. Now, coming to question number 7. One fundamental difference between monitoring product quality and service quality is based upon the fact that, okay, so here the question is asking what is one fundamental difference between monitoring the quality of a product and a service? Like, we all know, why is it harder or different to check quality in services compared to manufactured goods? Okay, difference between the service and product, which we have discussed in the last session. So here, now think about it. What is a product? It's tangible. Car, any drug or a device. It's tangible, it's manufactured, and it's possible for us to inspect the particular product before delivery, right? And then what is service? In our healthcare system, service is some surgery, in the nursing care, is a care delivered in that particular moment, right? And it involves people. So this is the basic difference between the service and a product. And once we know that, we'll evaluate the options. So here, what it's saying is option A service is easier to measure and verify in advance. No, because we all know services are harder to verify in advance because we all know, I mean, like, what do you say? It's quite opposite rather. Okay. Now, option B, a service is not perishable. Again, this is opposite because we all know services are perishable. Okay, because in a way, like an empty appointment slot is gone, unused OT time is gone. We can't reuse it again. They are perishable. So even this option is not right. Now, a service is more heterogeneous than an object. Yes, services vary widely because there is human involvement. Human interaction is there. It differs from patient to patient. It differs from a doctor to doctor or a nurse to nurse. Here, the service is heterogeneous. But whereas products, they are uniform in everything in that particular assembly line, right? So this is the nearer one. Now coming to option D, there are more service delays than product delays. It's an operational. It depends on the operations. It isn't related to quality monitoring. So this is also not the right fit for the question. So in a way, like evaluating all the options, option C is the right answer, right? Remember, to summarize, services are heterogeneous because they involve human interactions, both the provider as well as the recipient. Okay. So there are different patients, different doctors, different nurses, and also different contexts every single time. But whereas for the product, I mean, like a tablet or a device manufactured in a factory is identical, is very much identical across all the units, whereas a nurse care interaction is never exactly the same, right? So this variability or heterogeneity is why we monitor service quality, and it is fundamentally harder for us, right? It's easier for the product to verify before sending it to sales. It is easier to standardize the product or verify its quality before the delivery, right? But as far as the service is concerned, this heterogeneity leads to difficulty in monitoring. Okay, so that's the reason why we use audits, all the satisfaction surveys, HCAPs, right? And a sort of real-time observation rather than pre-delivery inspection, right? I hope you got the difference between the service and product and how it is. Now, coming to question number 8. The quality professional can best facilitate the development of a quality culture in an organization by doing what? Okay, so here the question is asking, as a quality professional, what's the best way to help build the quality culture in an organization? Or if you're a quality manager or you're a quality professional, what's your top role in creating the quality of a quality culture? Okay, So here it's, I mean, like, remember these keywords. It's talking about best facilitate. Okay. We all know quality professional is a facilitator and not the owner or the driver of the culture. Okay. We all know, we have already discussed, the leaders own culture, but quality professional enables it. Right. So here you should be knowing quality professional as a facilitator and the leader as the owner. Now, coming to options, assessing the organization's readiness to commit to change. Okay, it is useful, but it's an assessment step. It's not the best way to facilitate the culture. Readiness assessment is a preparatory step. It's more of a prerequisite, not the best method to facilitate the quality culture. Okay, so remember that this is talking about the step, and it's useful in change management, but alone it doesn't build the culture. Okay, now option B, designing a long range plan for cultural transformation. So remember, quality professional can contribute, but designing transformation is a leader's job. Plan design is a leadership and strategic function, whereas quality professional contributes data and expertise to that plan, but he doesn't own or design it. Okay, so designing a long range plan for cultural transformation is the leadership's responsibility and not a quality professional's responsibility. Coming to option C, encouraging leaders to commit to a culture of excellence. Yes, quality professional facilitates leadership commitment to culture of excellence. This is near. Now, coming to option D, leading the cultural transformation redesign team. Okay, quality professional may participate, but leading the cultural transformation is a way like overstepping the quality professional's role, because we all know that's leadership's responsibility, right? It's tempting for a quality professional to lead the cultural transformation, but ultimately it's the leadership's responsibility. We all know quality professional is a facilitator and not a leader. So this is also not in consideration. Remember, this particular thing and this particular thing are leadership's responsibility, and this particular thing is a step, but not a way to implement the quality culture. So the nearest and the best option is encouraging leaders to commit to a culture of excellence, right? Here we see the quality professional's unique role of an enabler, of a change agent. Okay, they can influence, coach, and encourage the senior leaders of the organization rather than owning the transformation themselves. They should encourage to adopt. Okay, in a way, like, think a quality manager doesn't say like we have a quality culture, safety culture now. Instead, what he does is he presents the safety data to the CEO, to the leader of that particular organization. He facilitates the leadership to go through that particular things about patient safety. And here the leadership will do in a way like own, and they walk the talk, they take the rounds. And here the quality professional acts as a facilitator. Okay. Now, coming to question number 9. The task of setting up an ambulatory care setting, QM or QI program that focuses on outcomes as a measure of treatment effectiveness is difficult because. So here the question is asking, why is it hard to measure treatment effectiveness using outcomes in an outpatient care settings? Or like, what makes tracking the outcomes or the how well the treatment actually worked in an outpatient setting so difficult? Okay, why is it difficult for us to calculate or to measure the clinical outcomes in an outpatient setting. That's the simplest sort of simplification of the question, right? So here, option A, the patient remains in control of treatment. Okay. Once the patient leaves the OPD, they will decide if they are going to take the medications. They are going to decide whether they're actually going to change the diet as advised or whether they are returning for follow-up. And we all know outcomes depend heavily on the patient's behavior when they are in an ambulatory care, because there is no one watching. It's the patient is in complete control of his treatment. Okay, this is a possible answer. Remember, when we are talking about ambulatory care, patient comes in, gets treated, go home, and we may never see them again until the next visit. What happens in between these two visits? The patient is in control of his treatment, right? So this is a possible answer. Now, option B, patient care outcomes are determined by the payer. No, payers or insurances will reimburse. They don't determine the clinical outcome. So this is wrong. Now, there are no required medical records. This is also wrong because even OPD does have the medical records. Okay. So this is a wrong premise. Now, coming to option D, expected outcomes for ambulatory conditions are too obvious. See, here, if anything, OP outcomes are harder to track and they are never too obvious. Okay, this is a reverse logic. And I mean, like OP outcomes are harder to define and track because the follow-up is not consistent. Timelines are very long, and in a way, like this is a sort of a trap in the question, trap in the exam. Remember this: if you see such options like too obvious or too easy, in a way, like stay away from those particular options and be suspicious. Okay, so this is also not the right option. Now it's a wrong concept, it's factually wrong, and then this is a reverse logic. So the correct option is option A. It's very difficult for us to measure the outcomes in an outpatient clinic because the patient remains in control of the treatment. So coming to question number 10. The quality management cycle based on Juron's quality trilogy, that is quality planning, quality control, and quality improvement. Which of the right is, I mean, like, according to Juron's quality trilogy, which statement is correct? Okay, what is correct regarding the Juron's trilogy? We all know Juron's trilogy includes quality planning, quality control, quality improvement, and it fits all the functions at all levels, at all products or service lines. Okay, so once we remember that, coming to the options, option A, it excludes the lab's activities to monitor equipment. We all know trilogy is universal. It doesn't exclude any of the departments. So it also includes lab, clinicals, and everything. So this is not the right answer. It requires a departmentalized approach to quality management. No, because we all know TQM and Juran and all the quality gurus reject the silos. Okay, so this is also wrong. Juran's trilogy encompasses only the non-clinical aspects of quality management, only non-clinical aspects. Remember, the trilogy applies to both clinical and non-clinical, covering all products, services, and processes in the organization. And just limiting it to non-clinical would make it useless, right? So there's no point of clinical quality if at all it only focuses on non-clinical aspects. So this is also wrong. And remaining, it incorporates information from strategic planning. Yes, because we all know quality planning begins with organizational goals like mission and vision, right? So once we eliminate all the three options, the right answer is that Juron's quality trilogy incorporates information from strategic planning, right? In a way, like just to remind, the planning, quality planning begins with organizational goals, policies, mission and vision. Okay. In a way, like from there itself, from mission and vision itself, the strategic plan is derived. And you cannot plan for quality without knowing where the organization's direction is or where its priorities lies. Okay. And especially in healthcare, quality management activities must align with hospital strategic priorities because those goals feed directly into quality planning. Okay. Now, coming to question number 11. The perception of quality by a patient receiving care in an ambulatory healthcare center is influenced most by what? Okay. So, in a way, it's asking what influences more, what most influences how an ambulatory patient perceives the quality of care. Like when a patient visits an outpatient clinic, what are the factors that shape his opinion of whether the care was good or bad? Okay. So here again, it's perception. Perception is subjective from the receiver end. We know that particular thing. And we have already discussed this in earlier question. Okay. So here the patients judge care through their own experience of interaction, and there is nothing to take from the technical specs, right? So option A, the physical environment. See, nice waiting rooms do help, but that's not the most influential factor as far as the perception is concerned, right? And caring staff and physician, yes, because we all know human interactions, including empathy, dignity, these are all classic perception drivers. This actually matches the respect and caring dimension perfectly. And coming to new technology, patients will rarely know if an MRI machine is latest gen tech or anything because the tech isn't visible or felt the way caring is. Technology impresses the user, it impresses the clinicians, but not typically the patients because most outpatients can't tell the difference between a 3 Tesla MRI or a 1.5 Tesla MRI. They just see the machine, but they can't exactly perceive the quality difference between the two machines, right? It's more of the times the doctors. Coming to option D, the physician's technical competence. See, patients cannot judge the technical competence of a physician. This is more of a what do you say, appreciative quality, wherein the peer physicians do, or the peer physicians can only judge the fellow physicians technical competence and not the patients. So here this is also not the right option. So option B, the perception of quality by a patient receiving care in an OP setting is influenced most by caring staff and physician, right? We have already discussed this particular thing. In our earlier questions also we have discussed. And also remember always, perception may not be, I mean, like perception will always not be equal to actual quality. It's only perception, it's subjective. It's only how they look, how they have experienced. Okay. So it's more of an interpersonal sort of thing. That's not actual quality per se. Now, coming to question number 12, total quality management philosophy assumes that. Okay, so it's asking what does TQM assume about where quality problems come from? Okay, most problems here they're talking about. Option A, most problems with service delivery result from systems difficulty. Option B, frequent inspection is necessary to improve quality. Option C, most problems with service delivery result from difficulties with individuals. And option D, top management leadership in quality activities disenfranchises employees. Look, we all know TQM and we can relate to Deming. We remember that slide wherein, and also the Deming's quote, 94% of the problems are caused by the system and not the worker. So that's what I remember in answering this particular question. Here, TQM philosophy assumes that, okay, option A, systems difficulty cause most problems? Yes, because this is a TQM's core assumption. Option B, frequent inspections improves quality. TQM actually rejects this particular thing. This is more of a quality, the old school quality thought, right? And most problems with service delivery result from difficulties with individuals. This again is a complete opposite of TQM. And this is old blame culture. Coming to option D, leadership disenfranchises employees. No. In a way like TQM requires strong leadership and employee empowerment together, right? So disenfranchising employment is against TQM. So the correct option is option A. Most problems with service delivery result from system difficulties. Okay, remember Deming and his quote. And this is something in your exam. This is one thing which you should be remembering, because this is one of the most important sort of lines that you should be remembering. Most problems with services delivery results from system difficulties and not from individuals. Okay. Now, coming to the next question. The function in the Juran's quality management cycle that includes the initial analysis of data or information is, here the keyword is initial analysis of data. Here is asking which function which function of Juran's quality trilogy includes initial analysis of data. Okay, so in which step the initial data is first analyzed? Okay, and that's what he's asking. So remember, quality trilogy, Juran's quality trilogy has quality planning, quality control, and quality improvement, right? So as far as I remember, quality planning, here what we do, we set the goal, identify customers, the design process, and it's forward looking. There is no data analysis in quality planning at all, right? So this is not the right answer. Quality initiatives, I mean, like we all know, quality initiatives is not at all present in Juran's quality trilogy. Okay, it's specifically asking regarding Juran's quality trilogy. Coming to quality control, it, we all know quality measures, quality control and quality measurement. Here in this, yes, we measure actual performance, we compare it to the goals, we see the gaps. This is where the data is first analyzed. Okay. And option D, quality improvement. Right. See, here, quality improvement is used to find and fix chronic problems. This comes after initial data analysis, not during it. Okay. So this is also not the right answer. And there is one more key. It's talking about initial data analysis. Here in quality control step, initial data analysis is done. And in quality improvement, intensive data analysis is done. There are two different things that you should be remembering. Okay. So that's one thing which you should actually remember. Quality control is initial analysis, quality improvement, intensive analysis. If it talks about intensive analysis, it should be the quality improvement is the right answer. If it's talk about initial data analysis, quality control, right? Now, coming to question number 14, a potential conflict between philosophy of total quality management and quality improvement in healthcare is a challenge in Deming's principle to, right. So here, understand this particular question. This is one of little confusing question. So here it's asking which of Deming's specific principles create a potential conflict when applied to healthcare quality, right? Potential conflict between philosophy of total quality management and quality improvement in healthcare is a challenge in Deming's principles. So here what is difference between the Deming's principles and a conflict within healthcare, right? So you all should know, eliminate numerical goals for management, right? So we all know Deming did say like we should eliminate management by numbers, numerical goals, substitute leadership, because all those targets and quotas drive gaming and have the fear instead of true quality, right? So in a way, like this is a sort of conflict that comes up a little, because in modern healthcare QI, we do use numerical goals, right? Like infection rates, turnaround times, waiting times, and all these targets are there. But Deming doesn't like to have numerical goals as a way to manage and judge people. Okay. So there is some sort of conflict here. But see, I mean, like, this is not much of a challenge. This is one of the things which we should be considering. Coming to option B, cease dependence on inspection. Okay. So here, Deming's point saying cease depends on inspection to achieve quality, eliminate the need for inspection on a mass basis. That's what Deming's point, one of the Deming's point says. In healthcare, though we heavily depend on inspection like activities like audits, chart checks, peer reviews, external accreditation surveys, these are all inspection type controls. Okay. The TQM ideal is prevention and built in quality. The practical reality in healthcare is that we still rely on inspection and checking. So, this is a sort of challenge to the Deming's principle as well. So, this also directly clashes with how healthcare often does quality. And when the Deming is talking about sees the dependence on inspection, but still healthcare does this particular thing. Coming to option C, constantly improve every process. C. This is exactly where healthcare quality wants, and also the Deming's TQM principle. So this is not the right question, right option. Coming to D, break down barriers between staff and areas of departments. Yes, both Deming also talks about it, and healthcare organizations also, for its quality improvement aspects, break down the barriers. So there is no conflict between this point, between the healthcare quality as well as Deming's principles are concerned, right? So there's a sort of conflict between these two options. Eliminate numerical goals for management, cease dependency on inspection. But here, remember, cease dependence on inspection to achieve quality. We should all remember that Deming's 14 points of managing quality were actually developed with the products in mind. And in a way, like, they were not for services. Even though they have been revised to accommodate the service industry, there is need for further adaptation in healthcare because a patient is a person and not a product. So once you realize this particular thing, you will understand where the conflict between healthcare quality and Deming's principles are. So the correct option for this particular answer is, for this particular question is option B, cease dependence on inspection. Even though Deming talks about ceasing dependence on inspection, we still depend on it with our audits, chart checks, reviews, external surveys, etc. Right? So these are all inspection type controls. Whereas ideal TQM says no to all these things. Coming to question number 15. What is the most important relationship between structure, process, and outcome as types of indicators of quality? In a way, like this, we have already discussed as one of the last topics of the last session. And we also, when we were talking about Dunabedian indicators of structure, process, and outcomes, right? So it's asking, like, what's the relationship between Dunabedian's three types of quality indicators of structure, process, and outcome? Okay, how are they related to each other? Here coming to the option interdependent. Structure directly affects both process and outcome. No, we all know it's close, but directly affects outcome. No. Interdependent, I mean, like they are linked. We all know structure leads to process and process leads to outcome. So it's not option A. Option A is not right because structure directly affects both process and outcome. It only directly affects process. Structure doesn't directly affect the outcome, right? It's causal. Structure leads to process and process leads to outcome. This is the right answer. Relational, useful for comparisons but not causal. This is also factually wrong. There is no relationship. There are categories used to group indicators. No. So the right answer is option B, causal relationship. They are causally related. Okay. Now, question number 16. Continuous quality improvement efforts find problems in hospital admission. So, to provide breakthrough ideas in admission, the quality team seeks ideas from. So, here the question is asking a quality team working on improving hospital admissions. Remember, hospital admissions, right? They want breakthrough ideas. Where should they look? Like when your regular improvement is not enough, you want some innovative ideas as far as admission process is concerned. Which industry should you look for your benchmarking? Right, that's what it's asking. I think the another keyword for this particular question is breakthrough ideas. Breakthrough ideas may, I mean, like breakthrough is like radical. It's not incremental improvement. Breakthrough means it's going out of the box, out of usual thinkings. And here another keyword is admission. So for this function, what is admission? Here you are welcoming someone, you are checking them in, you are orienting them to the space and making them comfortable, right? So two keywords, breakthrough ideas and admission as a function. Now, option A, other hospitals. Look, if you look into the same industry, you will get the same ideas, same constraints. You will find the best practices, but you will not find any breakthrough ideas. So, when you're looking at other hospitals, it's more of a competitive benchmarking, useful for comparing yourself with other hospitals, but it doesn't give you any breakthrough ideas. So this is not the right answer. Previous lecture, look, past knowledge is again like past thinking. There won't be any breakthroughs, right? This is a source of your knowledge, but nothing else. Looking at automobile industry, okay. Automobile industry is brilliant for process efficiency and lean manufacturing. Like for example, we all know Toyota Production Systems, Just in Time, or Pokayoke. All these models are in a way like excellent, but they are modeled on things or products. They are not modeled on people arrival. Here, the function of admission is missing. So automobile industry is also not. So here the right option is option D, hotel and resort industry, because we all know hotel and resort industry does have check-in, room assignment, there is personalized welcome, guest comfort, orientation to the space they are occupying. So this is what exactly a hospital wants to mimic or they wants to mirror in their admission process, right? So we all know hospitals have perfected all the admission sort of process. So here option D is the right answer. Okay. So this particular question is talking about the functional benchmarking, looking outside the own industry for a similar function. If at all, remember, if the function was, I mean, like if the function for a breakthrough idea is about admission, you should be looking into hotels and resorts. There are other industries as well wherein healthcare can look into for breakthrough ideas. For example, in case if we are looking into safety checklist, safety as an aspect, then the benchmark industry would be aviation. Okay. And if at all supply chain or any sort of inventory ideas are needed, we'll be looking into automobile industry. Okay. If at all we are going to have performance comparison and benchmarking, then you should be looking into your other hospitals in this within the same industry. This is regarding question number 16. I hope you got the concept here. So here, which of the following best describes the successful outcome of the quality improvement process? Here it's asking like, what is a successful outcome, the end result of a QI process? I mean, like when QI works well, what does success ultimately look like? So what are you working for, right? What is end result? What is the end result for your QI? Here, the options are the customer satisfaction. Yes, this is what QI ultimately wants, ultimately produces the better experience for patients and their families, more safer care, respectful care. It's an end result, right? It's an outcome. Here, the key is successful outcome. This is talking about outcome, and customer satisfaction is an outcome. Again, enhanced communication. Here, enhanced communication is not an outcome, it's a tool, it's an enabler of quality improvement. Okay, with good communication you can give good patient satisfaction, good process change, but in a way like you will reduce errors with it, you will improve coordination. Ultimately you can satisfy the customer or a patient, but this is a means and a tool, but not a successful outcome. Employee empowerment, again, this is also one of the tools. It's an enabler. When you empower the staff, they will drive improvement, right? It's a means, it's not an end or an outcome. And then improved statistical data, this is just a measurement tool. Okay, and if we remove all these three, the correct option is option A, customer satisfaction. Now, coming to question number 18. Monitoring the specific organization and content requirements of a medical record system is a review of which focus? Now, here it's asking when you are monitoring the specific organization and contents requirements of a medical record system. We all know Donabedian framework of structure, process, and outcome, right? So what are the indicators of a structural indicators, process indicators, and outcome indicators? So here it's talking specifically regarding medical record system and the content requirements. So here medical record system, as far as the structure is concerned, you see the setup of the medical record system, the contents which in the the content of the medical records, which are the required fields. Okay, the tools, resources, infrastructure, whatever it is, this all does come from a structure of the care. Whereas reviewing whether those particular content fields like history, physical examination, consents were done properly or not, if we check those documentation, that is process. And if you check what like in a way like what a doctor has documented during the visit, you will be looking at the process itself, right? Now, if you measure the rates or if you measure the outcomes, that will be coming under the outcome of care. Now coming to the options, outcome of care, this is a result of care, not applicable to systems organizational requirements. Process, clinical activities, but again, this is not. As far as structure is concerned, yes, resources, systems, facilities, policies, standards, everything, the content requirements does suit the structure. Administration of care, this is not in a Donabedian framework. So the correct answer is option C. Okay. And remember, if at all revisit the structure, process, and outcome indicators from our first lecture, and you'll be easily cracking this sort of questions. That won't be a problem for you. Now, the major difference between traditional quality assurance activities and the expanded quality improvement activities QI focuses on, right? So it's asking what's the key difference between traditional QA versus modern QI. So here the QI focuses more on what? Okay. So here, people and competency, look, that's exactly what QA focuses, not the QI. QI focuses on, so this is not the right option. Analysis of data, both QA and QI both do it. So this is also wrong. Performance measures, again, both use the measure. QA and QI both do it. So this is not exclusively to QI. So this is also wrong. QI focuses on systems and processes. Yes, QI is the paradigm shift was moving from blaming people to fixing the systems and processes. This is the right answer for it. Okay. In a way, like as far as QA is concerned, it focuses on people or individuals, and QI focuses on systems and processes. Okay. And QA is reactive and retrospective. QI is proactive and continuous. This is what we have learned in the first lecture. Now, coming to question number 20, monitoring phlebitis associated with IV insertions by nurses in the surgical intensive care unit addresses which focus? So look here, again, it's about structure, process, or outcome. Here, what is asking? Monitoring phlebitis associated with IV insertions. We all know the infection rates or the turnaround times. All this do come under the outcomes, right? So here, it's pretty straightforward. What is phlebitis? Inflammation after IV insertion. Okay. So this is the most probable sort of answer. What is structure in this particular thing of IV insertions? If at all the question asked regarding the policy for IV insertion, or if it was talking about the nurses available, or if the proper equipment was available, then the structure would have been the right thing, right? If at all monitoring how the nurse is performing the insertion, how the work is being done, what is the technique that is she following, or whether she was washing her hands or complying with hand hygiene policy before IV application, then it would have been the process. Okay, so both structure and process. But phlebitis occurring after the insertion, it is a complication, it is a result, it is outcome. So this does address the outcome of care, right? It's not an administrative procedure at all. So remember that. Now, coming to question number 21. The centerpiece of outcomes management in healthcare is what? So here it's asking what is the core of outcomes management in healthcare? What does it revolve around? Okay. So remember, outcomes management is a whole framework, and we did not discuss this outcome management yet. So this outcomes management is described as some sort of measuring what matters most to the patient. Look, here you have to remember outcomes management. Generally, what happens is, as a healthcare provider, what do you really focus on, right? You mostly focus on the clinical outcome of a patient. Like, did the patient survive after a procedure or not? Did the patient get discharged to home, coming to the hospital after a critical condition or not? This is what you as a healthcare provider do think about, right? That's an outcome for you. But here, outcomes management deals with what matters most to the patient. It's not just the clinical event, but how they feel, function, and live. Okay. So just remember this particular thing. So here, in a way, like, this term was coined by some Paul Elwood. Okay. So this is about a systematic measurement of the functioning and well-being of the patient. How is the patient functioning and living as a result of the care they have received? For example, two patients undergone hip replacement, both are successful, both survive, both get discharged, both have same clinical outcome, right? That's the outcome which you as a provider think about. But outcomes management system asks whether the patient is walking without any aids, whether the patient is going back to his usual routine, whether the patient is going to climb the stairs and live independently or not. That functionality of and quality of life is the difference between our simple outcomes and outcomes management. Okay, so that's the core, how the patient looks at his what do you say, treatment. After the treatment, how does the patient feel? That's the question. So the options are the measurement of patient's functionality and quality of life. Yes. Morbidity and mortality, this is more of a provider related sort of outcomes. Data reliability, not related to this. Financial impact, not related to this. So the right option is the outcomes management deals with measurement of patient's functionality and quality of care. Okay. Now, review of the timeliness of high risk screening for diabetes addresses which focus. Here it's asking again the Donabedian framework. What is it, a structure or process or an outcome? Again, here the key is a review of timeliness of high risk screening. Okay, so when you talk about screening, it is something done to or for a patient, right? Reviewing its timeliness, checking whether that particular clinical activity happened at the right time or not. Is it about any resources or systems? No. So it is not a structure. Is it about a clinical activity being performed? Yes. So it is a process. I'm like, is it about what happened to the patient's health? No. So it is not an outcome. Okay. And as we know, administrative procedure is not in the Donabedian framework. So when this is not a structure, when this is not an outcome, the right answer is B, process. When something is done, okay, when something is done, that is structure, that is process. Sorry. Okay. Now, the under the quality improvement paradigm, which statement is incorrect? So here, which statement is incorrect? In your exam, always remember to think loud about what the question is asking. Is it asking about the correct statement or incorrect statement? Because you may know the concept, you may know everything, but if you read your question wrong, then you're obviously going to answer it wrong. Always remember the keywords and in a way like focus on the keywords and then try to sort of solve the question. Here it's asking for a negative statement under quality improvement paradigm, which statement is incorrect, right? The focus is on competency of individual practitioners. Does quality improvement focus on competency of individual practitioners? No. The focus is on efficacy and effectiveness of processes. Yes. The focus is on the patient. Yes, because QI is patient centric. The focus is on organization performance. Yes. QI looks at the whole system or organization and not just at a person, right? So these are the three correct answers. But the question is asking regarding what statement is incorrect. So the correct option is option A. The focus is on competency and individual practitioners. This is more of an old traditional QA framework, not the advanced TQM or quality improvement paradigm related answer. Okay. Now, coming to question number 24. Within the context of total quality management philosophy, communication of quality is whose responsibility, right? It's asking who owns the responsibility of communicating quality throughout the organization. Okay. So here, the responsibility of top management leaders. Yes. We all know TQM explicitly states the quality begins and is sustained by top quality top leadership itself, their commitment itself. Okay, they set the message and everyone follows. And then it is delegated to quality management. No, it is not delegated. Responsibility is not delegated at all. And then an internal organizational, not community issue. No, it is within the organization as well as the broad community which it serves in, right? It also gives, I mean, like TQM is customer focused and also it includes external community. Okay, it must go beyond the walls. It's independent of process budgets and costs. No, because we all know quality comes with a cost. We all know cost of quality by Juran. So they are not independent in a way. So here the correct answer is option A. It is a responsibility of top management. And remember this one particular answer, there are many question types. There is a high chance that when it asks about the ultimate responsibility lies with the top management itself. That is their responsibility. This is one of the questions which is expected in the final exam as well. Okay. Now, the probability that each step in a process will occur as it needs to occur is known as. It's a simple definition question. Okay. So predictability. It's asking what is probability. Probability that each step in a process will occur as it needs to occur is. Okay. So what do we call the chance that every step of a process performs correctly as intended is the question. Now we should know the definitions of these four, right? So what is predictability? It is knowing in advance what will happen about future. It's not probability, it's predictability. Okay. It's the ability to forecast what will happen based on patterns. It's about anticipating the outcomes. It's not measuring probability of execution, right? So this is not the right answer. Reliability means the probability that a product, system, or service will perform its intended function adequately. So this does fit in. What is dependability? It's a broader everyday term of trustworthiness. Okay. There's nothing related to probability. And then consistency. Consistency means uniformity of performance. It's about sameness and it's not probability. Okay. Consistency means uniformity and repeatability of performance, doing the same thing the same way every single time. That's consistency. It's related to reliability, but it doesn't carry that probabilistic definition, right? So this is also not the right answer. The correct answer is B, reliability. You see, reliability means, for example, um surgical safety checklist has many steps, right? If each step is performed correctly, only 95% of the time, the probability of all 10 steps occurring perfectly comes only to somewhere around 60%. Okay. We will learn this particular thing in data analysis thing. So until then, just remember the definition of reliability itself. Okay, these measurements will get to know later on. Now, organizational culture mostly refers to what is organizational culture. Okay, so organizational culture means what? Option A, ethnicity of the organization's employees and licensed practitioners. No, because ethnicity of employees is a more of diversity. It's not organizational culture. Assumptions about people and how work gets done. Yes, this is the nearest sort of definition. The efforts to reach out to diverse groups in the community. This is more about community engagement and not regarding culture. The scheduled social and cultural events within the organization. I mean, like this is our service level activities, not the deeper assumptions of the culture. They are only a sort of show off, right? So option B, assumptions about people and how the work gets done here is the definition of culture. Okay. Now coming to question number 27. It's talking about prospective payment systems provide reimbursement. That is, here again, the definition of prospective. Remember, prospective means looking forward. That is determining in advance itself. It's before the act. Okay. So based on actual costs, no. It's not based on actual costs because this will become retrospective. Retrospective means after the action is done. So here you pay after calculating what was actually spent. So this is not the right. Based on charges, again, this is fee for service. I mean, like here providers charge per service and get paid per charge. This is again retrospective, so not the prospective payment system. It is determined prior to care rendered. Yes, that's what we were talking about. Prospective, predetermined before the care happens. Okay. So payment based on predetermined fixed amounts is prospective payment system. And again, it is determined with the number of members served per year. This is capitation. This is definition of capitation. Per member per month payments in a managed care are not related to prospective payment system. All these particular things you will come across again in the last chapter, hopefully. So until then, remember prospective payment system determined prior to the care rendered. Coming to question number 28. The key goal of reengineering is, here again, is talking about what is the ultimate key goal of reengineering is. Now you will have to understand what reengineering means first. Okay. So reengineering means it's a radical fundamental change. It's not like tweaking for gradual improvement. Okay. And it's a sort of radical redesign of any process, business process, to deliver more value to the customer. Okay. It's more about improving the process radically. All right. So that's what you'll have to see here. The key goal, it's asking about the goal of reengineering. Why are you going to go for reengineering? To improve the care process? No, for that QI process, QI is sufficient. Is it to satisfy the customer? Yes, this is one of the goals that we are working to. Why do you want to change things if they're working fine? Because I need to satisfy the customer. Now, is a position for change. Reengineering position for change? No, this is not. And then redesign the organization. This is a means. Reengineering is redesigning. But this is a means, this is a way, but not the ultimate goal. Ultimate goal is satisfaction of the customer. Okay. So see here, steps in business process reengineering. Once you define the objectives and framework, you'll have to identify the customer needs, because in a way like you are going to satisfy the customer needs, then study the existing process, formulate the redesign plan, and then implement the redesign plan. Redesigning the organization is a means of achieving the final objective of satisfying the customer. Okay. Now here, this is a sort of scenario based question. Okay, you will come across these questions as well. Here, the Steven Strong, who is 60-year-old, is recuperating from a total hip replacement procedure following a fall and fracture. He has a history of diabetes and in a way like and heart disease, and had an angioplasty just 2 months ago. He had been fully sufficient until the fall. Now, the hospital has a new transitional care center to which the joint replacement patients are transferred for post-operative physical therapy. Hospital is part of an integrated delivery system serving the community across the continuum of care. Use this information to answer the question. The integrated delivery system represents what type of healthcare? Here again, you need to ask. Integrated system, we all know, we have studied two types of integrated delivery system, that is vertical and horizontal, right? So here it's asking, the patient has undergone a successful hip replacement surgery. The hospital has a transitional care center. Post-operative physiotherapy is done. It's an IDS. A hospital is part of an IDS which is serving across the continuum of care. What sort of organization is it? As far as remembering the types of IDS are concerned, horizontal and vertical. In horizontal, we see same type of facilities joining, like multiple hospitals merging together. Whereas in vertical, different levels of care joined across the continuum, like a hospital, OP, hospital, rehab, primary care, again home health care, etc. Right? So here we see that the patient, this particular patient, is going from a hospital to a transitional care center to physiotherapy to home. Different levels of care. That is the definition of vertical integrated delivery system. Okay. Same stage is horizontal, different stages is vertical. Now, the same scenario, but here it's asking, he has a history of diabetes, of heart disease, undergone angioplasty 2 months ago. And here, the hospital has new transitional care center to which total joint replacement patients are transferred post-operatively. Across the country, use this information. And as part of integrated delivery system, the transitional care center will best meet Steve Strong's needs through what? Option A, case management. Option B, continued physical therapy at home. Option C, diabetic disease management or home evaluation through occupational therapy prior to discharge. Basically, the question is asking, as part of IDS, transitional care center will meet Steve Strong's needs through which type of care? Okay. With all his conditions, you remember, this is a complex health profile of the patient. How will transitional care meets his need? He has hip replacement, he's diabetic, he has had recent angioplasty. What is one best approach to coordinate everything he has? Option A, case management. Remember, case management, case manager coordinates all a patient needs across the full continuum of care. It looks after cardiac, his diabetic issues, his rehab, then at home preparation. So it matches the integrated delivery system's purpose. Continued physical therapy at home, it only looks into physiotherapy and it ignores cardiac and the other things, right? So this is not the right option. Diabetes disease management, again, this is disease specific. This is only looking at diabetes lens and not the other things. It's ignoring all other things. Home evaluation through occupational therapy, again, the single focus. Only case management approach helps this particular patient through comprehensive care, because Stephen's case manager will help to coordinate with daily physiotherapy, daily blood sugar monitoring with the specialist, cardiology follow-up if required, and then safety at home, and then with the medication reconciliation, discharge planning, all in this particular IDS. So the correct option is case management. Now, in an inpatient stay, specific patient conditions that are present on admission and require treatment during the stay are called. So here it's asking, what is the specific medical term that the patient conditions that were already present at the time of admission, but which require treatment during the hospital stay is concerned? Is it complications? Is it comorbidities? Is it community acquired, or is it healthcare associated? Remember, the key is present on admission and requires the treatment. Okay. So complications means what? It is developed because of the treatment within the hospitalization. They can happen during the stay, but it can't be before the admission, right? So complications are adverse events or new conditions that arise as a result of treatment or hospitalization. They were not present at the time of admission. Like in previous question, we have discussed phlebitis related to IV insertion, right? Phlebitis was a complication there. Okay, so this is not right. Comorbidities, yes, additional conditions existing alongside the primary diagnosis at the time of admission only is called comorbidity, right? Community acquired means an infection that is acquired outside the hospital. I mean, like this only talks about the infection, no other things like diabetes, hypertension, cardiac issues, etc. So this is a narrow focus for the description. Healthcare associated, again, this is within the hospital setting. Okay, healthcare associated conditions within the hospital settings after admission, right? So the correct option is option D, comorbidities. The difference between complication and comorbidity. Now, the interdisciplinary team is charged with creating a new admission process that will radically reduce current delays and waiting times. The team is looking for what? Here, the keywords for this question are new admission process, radically reducing the current delays and wait times. So, again, when you think about radically reducing and creating new admissions, this is something dramatic. This is not incremental tweak. Okay. So radically means it's not gradual. It's not incremental. Hence it is not CQI. Okay. So first option is ruled out because we all know CQI is incremental step by step improvement, right? And then also creating new admission process means it's not building upon what exists. It's a redesign or a sort of breakthrough. System thinking, I mean, like this is a tool. This is not a complete improvement type. Breakthrough improvement, yes, possible because we see it matches radically perfectly. Okay, and also breakthrough looking for a new process entirely. Okay, process reliability, again the probability of process steps occurring correctly, which we have discussed earlier. Process reliability doesn't fit into this particular question. So the correct answer is when the interdisciplinary team is charged with creating new admission process that will radically reduce current delays, that's breakthrough improvement. Okay. In a way, like for example, if I want to discuss what exactly breakthrough improvement is, if let's say an admission process or a discharge process has multiple steps and takes somewhere around 10 to 3 to 4 hours, but a completely new process or a radically designed new process reduces that wait time for something around 20 minutes and it has only 3 to 4 steps. That's radically designed. That's a breakthrough improvement. That's not incremental. Okay. So here the right answer is C, breakthrough improvement. Now coming to question number 33. Healthcare quality professionals facilitating the assessment of impact of organizational culture on quality should evaluate at the very least uh, the organization's degree of compliance with what? I mean, like it's simply asking, if at all, as a quality professional to check if the culture supports quality, what is the most basic starting point for you in any organization? So here the options are the budget, mission and vision statements, the strategic plan, or the policies and procedures. See, as far as the budget is concerned, financial compliance is there, but it's not, it's operational, but it's not foundational for cultural assessment. So this is not the right answer. Assessing mission and vision statements, yes, because we all know the stated values and purpose of the organization, the very definition of what culture should be comes from the mission and vision statements of the organization. Strategic plans, no, because strategic plan come from mission and vision of the organization. They are derived. Strategic plans are derived from mission and vision. It's secondary, not the primary and the basic one. Policies and procedures, these are operational documents. These are too specific and in a way too narrow for a culture to look into the baseline, right? So the correct answer is option B, mission and vision statements. Now, question number 34. Sunshine Community Medical, again, scenario based. Sunshine Community Medical Center is merging with 3 other hospitals and their IPS and home health agencies to form Sunshine Healthcare Network. In a way, like this is integrated delivery system. Okay. So the new idea's vision is to create a seamless continuum of care within the region represented by their communities. Healthcare quality professional is part of a team working on the redesign of quality management program into an integrated system-wide quality strategy. Consider this scenario in answering the question. The system-wide merger and redesign best meets the definition of what? Okay. Which type of organization change does this merger and complete redesign of quality represents? Okay, we see there are 4 hospitals, IPS, home health agencies merged to form a brand new IDS. Okay, so in this, with entirely redesigned QM, what is it called? What is this process called, right? Is it restructuring? Is it right sizing? Is it downsizing or it re-engineering? So coming to restructuring is reorganizing existing structure, adjusting reporting lines or consolidating departments. This is more of incremental, right? So this is not the right fit. Right sizing means adjusting workforce to the right size. It's more about headcount optimization and not related to this particular scenario. Is it downsizing? Is it reducing the size, cutting staff? I mean, like this is not. This is going the opposite side. And then reengineering, fundamental, we have already know, fundamental rethinking, radical redesign of the organization, its process. So this is the most probable answer. Reengineering is redesign, new ideas, system-wide, seamless continuum. So option D is the right answer. Now, coming to question number 35. Again, in a way like the same sort of thing, same scenario. The organizations involved in the redesign must each commit to what? Okay. What mindset and commitment does each merging organization need to make this new idea system actually succeed? Is it preserving their own culture? Is it incremental change? Is it the fundamental change? Or is it their own leaders? So, see, preserving their own cultures, again this will create the silos, this will keep the old culture within those particular units, so this entirely defeats the purpose of ideas. So this is not the right answer. Is it incremental change? No, we already talked that this is a radical redesign and incremental is quite opposite. Is it fundamental change? Yes, reengineering by definition requires fundamental rethinking and commitment to deep structural change from everyone involved. So fundamental change is the probable answer. And the must commit to their own leadership. Again, this is, I mean, like if at all they are clinging to individual organization leaders, this again creates silos. Okay. So this is not the right answer. The correct answer is fundamental change. Now, within the same scenario, again, here it's asking to create seamless continuum of care, the Sunshine Healthcare Network will first seek to do what? In a way like to create seamless continuum of care, what should the Sunshine Healthcare Network do first? Okay. So the options are consolidate locations. See, physical consolidation may happen later, but it's not the first sort of step to do. Integrate financial planning, information system and marketing. Yes, because these are the foundational and connective, a sort of connective tissues for the ideas, right? Because the shared financial finances will make their alignment with incentives. With shared information systems, allow patient data to follow them. Marketing creates unified patient access. So this is the most probable answer. Expanding technology to all locations. Yes, technology expansion supports integration, but this is not the first thing to do, right? And incremental process improvement, focus on incremental process. No, we are talking about reengineering and radical improvement. So this is not the right answer. So first thing to do is to integrate financial planning, information systems, and marketing. Now, question number 37. In the transition from quality assurance to quality management or quality improvement, which of the following emphasis has resulted in most significant benefit? See, it's asking simple. From QA to QI transition, which single shift produced the most significant benefit? Okay, from older traditional thinking to the new new thinking in quality improvement or quality management, which single shift produced best results? Okay, so a sort of paradigm shift. Option A, focusing primarily on process rather than individual performance. Yes, because this is one thing which has actually led to huge benefit. Because remember that Deming proved that most of the problems are within the systems and processes. When you fix the right source, that leads to most significant benefit. Option B, focusing on organization wide rather than clinical processes. No, because expanding scope is a benefit, but it's secondary to correctly identify where the problem originates. So this is not the right answer for this question. Organizing activities around patient flow rather than department or anything. In a way, like patient flow rather than breaking silos is important, but a consequence of process thinking, and it's not the primary shift. Okay, so this is also not the right option. It's initiating more prospective rather than retrospective improvement efforts. See, moving from reactive to proactive things is important, it's meaningful, but it's a more of a technique evolution, not the paradigm's foundational benefit. Here, all these four options actually relate to the benefits or the core of modern quality management or quality improvement. But the best of the results have come up. The significant benefit has come up with the paradigm shift of focusing primarily on processes rather than individual performances. Coming to question number 38. Attempts to align with financial incentive of purchasers, payers, and providers will with provider performance on clinical processes and outcome measures could encourage what? So here it's specifically asking, if we align the financial incentives of all three key stakeholders like purchasers, payers, providers with clinical quality performance, what it encourages? In a way, like it's asking, when money follows quality rather than volume, or what change does that motivate organizations to make? See, for example, here it's asking, if the incentives are based on both the processes and outcome, what will the organization focus on? As simple as that. Okay. You see, when financial survival depends on how well you perform your clinical duty, not just how much you do, what's the pressure that has on the organization? Is it underutilization? No, because in a way, when a provider gets a fixed amount per member per year, there's in a way like there's a sort of incentive to do less, right? But here, aligning with clinical process and outcome measures means it's not performing indicated services would lower quality scores and reduce payments. It's in a way like discouraging the underutilization. It's not encouraging underutilization. Okay. Will they face community backlash? There's no logical connection between financial incentives and community backlash. Okay. In case if we come up with financial incentives for better process and better outcomes, that would actually for the benefit of the community. So there's no question of community backlash as well. Will it encourage overutilization? No, because overutilization means unnecessary tests, procedures, etc. Right? It's a classic risk of FFS, fee for service payment. Okay, more service means more revenue. But performance-based payment, it ties to quality outcomes, not for volumes. Okay, so in a way, this also is not the right option. Yes. Will it encourage reengineering? Yes, because when the financial incentives are there, financial survival requires dramatically better performances on your part. Then you'll have to think outside the box. You'll have to think to get the best sort of process design, and you need fundamental redesign of how you deliver the care. So the organization will be looking to have the re-engineering done for their entire processes in order to get their incentives, financial incentives. Okay. Coming to question number 39. After defining internal external customers, your organization is making a master list of each type of customer before initiating a major change in the process. Of the following, which is the best next question to ask? So here what exactly the question is asking is, like, they are making the master list of both internal and external customers. What is the question that you are going to ask, right? As simple as that. This is self-explanatory. We all know who is a customer. Customer is a person who receives your service. Supplier means the person who gives you something. Okay. Option A. Who do you receive services from? Means who are your suppliers? Here they are preparing the master list of the customers. They are not preparing the master list of suppliers. So this is not the right answer. Who in your work day do you serve? Yes. Serving someone. If they come up with you are serving, I mean, like for example, if you go to a pharmacy or a radiology department and ask who do you serve, he will say, I serve the ER department, I serve the nurses request, I serve the doctor's request, and I serve the patients. So these are all the customers list that he's telling it to you. So this is a question that you should be asking. Who in the workday do you serve? Now, coming to option C, which patients receive your service? This is only talking about external customers, not talking about internal customers. How do you know a customer from a supplier? This is the definition, or are you asking the awareness of that particular department regarding whether he knows who is a customer and who is a supplier or not? So this does not help us. This particular question will help us formulate both external and internal customers of that particular process. Now, coming to question number 40. Process indicator is defined as one that measures, like we have already discussed, structure, process, and outcome. Structure is what are the facilities that you have, what are the documents, what are the protocols that you have, all the tangible things. Process means what is being done, what is the activity, any sort of clinical activity that is done to or for the patient. Okay, the work done is a process. What are the results of that particular work done is the outcome. Now, looking into the options, process indicator, significant event that require further investigation. This is a special cause event or a sentinel event. Okay, so this is a sentinel event indicator, so this is not the right answer. An activity carried out to provide care or service. Yes, this does define the process. Unexpected or negative variation, this is more talking about adverse event and is not talking about process indicator. This is talking about outcome. Okay. It's more of sentinel event again. And then appropriateness of procedure or treatment. This is the dimension of quality which we have earlier discussed about, and this is nothing as far as the process is concerned. Okay. The right answer is process is an activity carried out to provide care or service. Question number 41. So the following is basically reviewed to determine the medical necessity and appropriateness of service delivery in inpatient care. In a hospital setting, what is the specific review process that checks if patient should have been admitted or not? Okay, so medical necessity for appropriate service delivery in inpatient care. It's here the thing is medical necessity and appropriateness. These are the keywords that you should be looking into. Okay. Remember, in utilization management review, admission review in inpatient settings, they do review the admission, they do review what happened during the stay, and they also review the discharge. So, was it necessary? Was admission appropriate or not? They do check all these things. Okay. So, admission review evaluates whether the patient needed IP level care at the point of entry. Does it match for medical necessity and is appropriate or not? Okay. So, medical necessity appropriateness is admission review. DRG validation, diagnosis related group validation. This is more about coding and billing thing. Okay, this is billing and reimbursement thing, not related to this particular question. Is it a procedure review? No, procedure reviews whether a specific procedure were appropriate or not. It doesn't talk about medical necessity and appropriateness. Okay, quality audits. These are retrospective quality review, not systematically focused on medical necessity. Medical necessities does not cover medical necessity. So the right answer is option A, admission review. And remember, these are the things that we have in utilization management as far as inpatient settings are concerned. Admissions are reviewed, the care delivery is reviewed, continued stay, discharge, readmissions. Whereas in outpatient settings, the visits, the treatment, other encounters, whether referrals and revisits, all these are reviewed. Okay. Now, when evaluating how many people in the facilities managed care plan were able to receive the flu shot under dimensions of performance, in a way like the question is asking like which quality dimension is being measured when you evaluate how many people in a managed care plan or in a managed care plan were able to receive the flu shot. Okay, like see, you'll see how many people are there in your managed care plan and how many were able to receive the flu shot. Okay, then which dimension of performance is it? Okay, so here the key is were able to receive the flu shot, were able. Okay, so it's not about not receive, it's not benefited from, but how many were able to access it. Okay, so were able to receive is the clue here. Is it appropriateness? No, because was a flu shot the right intervention for these people? Not, I mean, like that's not being measured here. So whether it is right or wrong is not being discussed. So this is not appropriateness. So coming to availability, the degree to which services can be obtained when needed or in a way like shortcut to able to receive, that's called availability. Yes, this fits into the keyword. Effectiveness is outcome, right? It's more about how well the flu shot actually improved health in the real world conditions is outcome, is effectiveness. So for this particular question, this is not, efficacy. The capacity of the flu shot to work under ideal conditions or the vaccine's power is efficacy. So this is not the right answer. Here, were able to receive the flu shot is the keyword for availability. Okay. Now, coming to next question. A radiology department regularly monitors X-ray repeat or reject, timeliness of report dictation, and patient waiting times. What component is missing in this department's ongoing evaluation? So it's asking a radiology department monitors three specific metrics. What is missing from the evaluation, right? So what are they not doing? Okay, so in a way like they are monitoring X-ray repeat or reject. So here technically they are looking into technical quality of imaging. Here they are monitoring the quality control. Okay, here they are monitoring the quality control. They are also monitoring timeliness of report dictation. So it's a clinical activity. They are doing the process related evaluation, right? And also measuring the patient's waiting time. So again, this is also a process evaluation because waiting time, service delivery timeline, process evaluation. Now, in a way, like what is the missing in this department's ongoing evaluation? Missing. Okay. Appropriateness review. I mean, like, are the X-rays being ordered, whether they are indicated and appropriate, are they necessary? They're not measuring this, right? They're not measuring this. Process evaluation, they're already doing it. They are doing the timeliness as well as waiting time. So process evaluation is being done. So this is not the right one. Quality control, yes, they're monitoring X-ray repeat or reject rates, right? So quality control is also taken care of. Documentation analysis, I mean, like this is partly captured in dictation, report dictation. Okay, document analysis is being done in a way. So this is not a major gap. So this is also not the right answer. What they are missing is appropriateness review. In a way, like in this particular question, they are not looking into whether that X-ray is clinically indicated for that particular patient. Was it necessary or not? Okay, so without appropriateness review, I mean, like, they can't. I mean, like that's what missing in this particular thing. Okay. Now, coming to question number 44, zero waste in particular equipment, supplies, ideas, and energy means what? Okay, so this is again the keyword zero waste. It's talking about resources. Okay, this is about utilization of resources, minimum sort of wastage, zero waste almost. So it's talking effectiveness. We all know the keyword is outcome. Efficiency, the keyword we all know is the capacity, right? And appropriateness, we have already known. What do you say? Sorry, efficiency. This is not efficacy. This is efficiency, right? So efficiency is optimal utilization of resources. So here the focus is on reducing the wastes. So this is the right answer. Appropriateness, no, we have already seen this is not related to appropriateness as well. What is equity? What is equity? So equity is, what do you say? It's a sort of fair distribution of care regardless of patient's sort of characteristics. It's about fairness, and there is nothing to do with the resource thing. Okay, so this is not the right answer. The right answer is efficiency. Okay, getting maximum result with minimum wastage of resources. Now, coming to next question. Appropriateness of appendectomy. So here it's talking about what actually helps in establishing the appropriateness of appendectomy. So here, whether it is pre-admission test, whether it's a pathology test, whether it's age or the clinical test, how will you determine whether the appendectomy was appropriate for a patient or not? Okay, so think about it. Pre-admission test, it supports the pre-operative diagnosis, but this is not foolproof. Okay, so pre-admission test show why surgeon thought appendectomy was needed, but it does not prove that it was actually necessary in a retrospective manner. So this is not. Pathology test, yes, it's a gold standard in a way. Pathology test, because it confirms the clinical diagnosis of the appendicitis. Okay, so if the pathology shows the real disease, if the pathology shows that the appendix was inflamed, then it was appropriate to do appendectomy. If at all the pathology test was negative, then it was inappropriate in a way. Okay, retrospectively, this does help in establishing the appropriateness of appendectomy surgery. Age, it has nothing to do with the appropriateness. Clinical testing, yes, in a way, like before surgery, clinical test does help to evaluate, apart from Alvarado score and other clinical sort of parameters, we can come to a conclusion whether the appendectomy is needed or not. But in retrospectively, after the procedure is done and appendix is sent for biopsy for pathological test, only then we will get to know whether the appendix was inflamed or not. Okay, whether there was any pathological changes or not. So here the pathological test is a gold standard for establishing the appropriateness of appendectomy. Okay, if at all it asks about before surgery, then clinical testing, clinical judgment is the final answer for appropriateness then. But overall, retrospectively, pathology test is the gold standard. Okay. Now, coming to the next question, 46. After administration of flu vaccine, quality professional measures how many people caught influenza after administering the vaccine. What is the dimension that they are measuring? So here the question is, how many people caught influenza after administering the vaccine? Here the question is not talking about any setting. There is no specificity whether it was controlled or whether it was in the real time thing. And also the key is how many people. How many people is more about capacity. Okay. So counting how many people got vaccine, how many vaccinated people got the flu. Okay. So it's talking about that. Here, prevalence means it's an epidemiological measure. It's not a quality dimension. Okay. So this is not the right answer. Process, again, it's the act of vaccinating, not counting who got the flu afterwards, right? Appropriateness, I mean, like, was the flu vaccine indicated for that particular population or not? It's not being measured here. So ultimately, how many people, capacity in controlled setting, efficacy is the right answer. Now, a quality manager is determining how many patients still became sick from influenza after receiving flu shots at his facility. Which dimension of performance is he evaluating? Again, here, if at all it's talking about how many, again, the capacity, but in a way, it's talking about how many people became sick even after receiving flu shots at his facility. At his facility, it's more about non-controlled sort of setup. We all know efficacy is the capacity of a drug to achieve successful outcome in a controlled setting. Sorry. Effectiveness is an outcome in real-time settings wherein we have different parameters, different characteristics of the patients, drug adherence, comorbidities, etc. Right? So in real-time facility, the dimension of performance he's evaluating is effectiveness. Okay. Prevalence, again, this is more about he is not talking about appropriateness. He is not talking about safety. The confusion is between effectiveness and efficacy. The correct answer for this is B. Sorry, effectiveness, because at his facility, real time setting, not controlled. Now, a patient diagnosed with hepatocellular carcinoma is receiving a novel chemotherapeutic agent based on promising preliminary data from clinical trials and absence of other viable treatments. The dimension of quality for which medication was chosen is its what? Here again, he's talking about clinical trials. That's a keyword, and is talking about absence of other viable treatments. So here his two keywords. The most probable answer is efficacy. Effectiveness, there is no study for real-time settings, so we are not supposed to think about effectiveness. Safety, again, maybe, but here again there is nothing that relates to safety in the question. Appropriateness, I mean, like, was it the right treatment for the right patient? But there is absence of other viable options, right? So it does mean, I mean, like, it does lean towards appropriateness. This is a context enabling choice, right? So, but that's not the only thing. Whether it is appropriate or not, it's not asking whether this particular thing is appropriate or not. It's more about preliminary data, means it knows the capacity of that drug, okay, and its performance in absence of other viable treatments. So the keyword relates to efficacy. Okay. Now, coming to question number 49. For which aspect of care are patient reported outcome measures most credible? All right. Here is asking, like, PR prompts measure what patient themselves report. For which aspect of care is patient the most reliable, uniquely qualified reporter over here? So here again, we are supposed to know that this is a perspective. perspective characteristic, perspective domain from the patient's side. Okay, he's asking which aspect of care are patient reported outcome measures most credible? Is it communication between providers? No, because this is a communication between two providers. The patient can't report this particular thing. Is it patient provider interaction? Yes. Is it adherence to clinical practice guidelines? No, the patient can't see whether the clinical practice guidelines were adhered to or not. So this is not the appropriateness of therapy. He can't judge this. So the only valid logical answer is patient provider interactions, because that's perspective from the patient's perspective only. So that's what he will relate as well, report as well. Now, coming to another question, question number 50. The primary purpose of the survey is to measure what? Is it patient expectations? Is it capacity of the process? Is it competence of the staff? Is it utilization appropriateness? Here again, remember the primary purpose here is the patient expectations. We'll know what the patient expected from care, and these surveys are literally designed to capture this particular information to see the patient satisfaction. So this is the most probable answer. Other options, capacity of the process. See, it's measured through the statistical process control. This is not the right tool. Competency of the staff, it can't be measured through survey. It is measured through credentialing. It is measured through peer review and direct observations. Okay. Utilization appropriateness, I mean, like, this is through utilization review of clinical charts, chart based, and is never the survey. Okay. Right option is patient expectations. Question number 51. Here, for CQI to be successful, who must be included in team? Look, I mean, like, he's asking for a CQI to be successful, who must be included in team? Okay. Whether it is department supervisor or administrator or a facilitator or a staff. So the most important one out of these four, right? Is it department supervisor? See, supervisors provide the context, but they are only line managers, not a dedicated CQI role requirement, right? Administrator, again, they support, but they are not a must-have sort of thing in the team. Facilitator, yes, the facilitator who knows the CQI process in and out helps keep them in track. He applies the QI methodology. He will help in implementation of the CQI, and hence he is required. Staff, frontline staff know the process, essential contributors, but one of the several required members, right? So in a way, like, administrator may not be required. It's good to have, in a way, like, may not be required. If he is there, he's helpful. But for us, if the facilitator is not there, they don't know how the CQI is supposed to be done. There is no facilitator who guides them. So for CQI to be successful, the must-have person in a team, okay, is the facilitator, because his role is to guide the QA process. He applies the methodology and manages the entire group dynamics, right? Staff are the primary source of knowledge for us. They know the processes. They will implement. They are important to have. Okay, department supervisor, he has the operational authority, and he can he can provide the resources for that particular department, but not for the entire ones. So in a way, like, if the question is not talking about the department or a unit, then facilitator is the right answer. If the question would have asked regarding that particular department, then he would have been the answer as well for that. Okay. Now, similar question, but for CQI to be successful, who must be included among the staff? Among the staff, who is supposed to be included? Whether it's the administrator? No. Person performing processes? Yes. Quality management representative from the staff? No. because we want to implement, we want to succeed in CQI. Is it department supervisor? Yes, in a way, but if at all we don't have persons performing the process, having department supervisor will also doesn't help for us. So anywhere the process owner is very much important for us to be in the implementation side of the CQI. Remember this particular thing. We are supposed to take inputs from the process owner because they know in and out about that particular process. They know about the pain points. They know about everything. And once the CQI design is done, they are the ones who are going to implement and achieve success, right? Coming to question number 53, who is responsible for quality improvement within organization? It's talking about who is responsible for quality improvement within organization. Is it the quality manager's responsibility? Or is it frontline staff's responsibility? Is it everyone's responsibility? Or is it solely the leadership's responsibility? Remember, quality is everyone's responsibility, right? So it doesn't, I mean, like, it doesn't lie with the leadership. It doesn't lie with the frontline staff. It is everyone's responsibility. Okay. There is no second thought about this particular answer. Now, coming to question number 54. Quality and technical performance refers to how well current scientific, medical knowledge, and technology are combined in a given situation to produce the best possible outcome. This joint combination is usually assessed in terms of. So here, to understand the question describes the technical performance, one of Donabedian's two dimensions of quality care. Okay, so here the key phrase is how well current scientific, medical knowledge, and technology are combined. In a way, like, this is clinical technical dimension of quality assessment. Okay, let's go through the statements. Appropriateness of therapy and other medical interventions are applied. So see whether the right treatment is applied to right patient at the right time based on current scientific evidence. That's what appropriateness is, right? Appropriateness is defined as the right treatment to the right patient, right time, according to evidence-based. Okay. It ensures that chosen interventions are justified, safe, and evidence-based. Okay. So this is in a way like the right answer. The quality of interpersonal relationships. See, quality of interpersonal relationship providers is through communication, through empathy, dignity, and patient preferences, right? So it is not through science and technology. So this is not. Timeliness and accuracy of diagnosis. Yes, accurate and timely diagnosis is important for as far as technical quality is concerned. And without a correct timely diagnosis, even the most appropriate therapy becomes irrelevant or harmful sometimes. So timeliness and accuracy of diagnosis is also right. So the correct answer is options A and C. Both answers A and C are correct. Okay. Coming to question number 55. Crossing the quality chasm provides a blueprint for future that classified and unified the components of quality through 6 aims for improvement, chain of effects, and simple rules. The 6 aims for improvement viewed also 6 dimensions of quality, and the following is out of those dimensions. So basically he's asking the Institute of Medicine's Crossing the Quality Chasm report, which defines 6 aims of improvement, also known as 6 dimensions of quality. Which of the option below is not one of this? Okay. So IOM's quality crossing the quality chasm has STEEP, STEEP. Okay. That is safe care, effective care, efficient care, equitable care, timely, and it is patient-centered. Okay. So here it's asking what does the quality chasm, crossing the quality chasm and key dimensions of quality differ in a way. Okay. So the options are safe, efficient, effective. All the safe, efficient, and effective are appropriate for both these things, but care centered is nowhere. Even if it is patient centered, then probably this would have been an answer as well. So here the care centered is not among both this crossing the quality chasm or in the dimensions of quality. If at all we consider care centered as patient centered, then it is included in STEEP, but is not in the dimensions of quality. So the correct answer is D. So here, remember, what is STEEP? Safe care. What does safe care means? Because this was not discussed in the quality basics. Safe care means avoiding harm to patients from care. Okay. Timely means reducing the wait times and delays, and also giving the care at appropriate time. Effective means again providing services based on scientific evidence for better outcome, and then efficient means avoiding waste, utilization of resources. Equitable means it does not vary by person to person, and it should be equal for everyone. And then it is patient centered. Patient centered means a sort of care that respects individual patient needs and values. Okay, remember STEEP: safe, timely, effective, efficient, equitable, and patient centered care. Now, coming to question number 56. Which of the following situations best describe the term misuse of resources at healthcare facilities? So it's asking basically what is misuse, what is overuse, and what is underuse. Okay. So the patients receiving appropriate medical care services that are provided poorly, exposing them to added risks of preventable complications. Yes. Okay. This is the one which fits the misuse. Patients undergo treatment or procedures from which they do not get benefited. If there is no benefit at all, but still they are being done, that's the definition of overuse. Okay, that's the definition of overuse. Patients do not receive beneficial health care. If the patients do not receive beneficial health care, that is underuse. Okay, misuse is patients receive appropriate medical care, but they are provided poorly, exposing, like there is preventable complications present. So that is the definition of misuse. Overuse is patients undergo the treatment or procedures which are not beneficial, which are not necessary. Underuse is patients do not receive beneficial health care. Okay, that's the difference between the three. Okay. Now, coming to question number 57. Mortal. Okay, mortality reviews are a critical element of risk management and quality improvement conducted to determine. Okay, so he's asking what is the primary purpose of mortality reviews in risk management and quality improvement. Okay, so here, is it to know if the practitioners involved were appropriately licensed and credentialed? No. Like this is done through staff privilege and credentialing function and nothing to related to mortality review. Is it if the treatment and patient care was adequate and appropriate? Yes. Who was responsible for mortality and what disciplinary action needed to be taken? No, this is not the primary motto. Because this is more of a punitive and blame culture. Okay, blame focused approach. This is quite opposite of CQI, because we all know mortality review should be non-punitive and it should be system focused. Okay, that should be looking into what was the treatment that was given, what were the appropriate, was it appropriate or not, just for improvement's sake. Okay, that should not be punitive. It should be non-punitive and systems focused. Will it see what the unit staff was doing at the time? Again, no. This also, it's more of a surveillance or incident investigation behavior. It's not the structured purpose of mortality review program at all. Okay. So the primary goal of mortality review is, in a way, what are the, was it appropriate treatment were given or not? And then to identify the systemic or process issues and then prevent future similar deaths. Okay, it's nothing to do with credentialing verification. There should not be any sort of punitive actions and blame culture. Okay, that's what it is. The right answer is option B. It is to conduct it if the treatment and patient care were adequate or appropriate or not. So these 57 questions were regarding the quality basic cases. Now, in the next class, we will be going through the quiz first. We'll be asking the questions. You people will be answering along with me. I'll be explaining it, and then we'll go on to the leadership session. If at all you have any doubts till now, kindly ask and I'll be answering them.